All right, let's dive into two really important areas of medicine, geriatric and palliative care. Now, these fields are all about one thing, improving life for people who are dealing with complex health problems. And the best way to see how they actually work, we're going to follow a single, powerful case study from start to finish.
So just imagine this for a second. Think about an older loved one, maybe a parent, a grandparent, someone you've known your entire life. And then, suddenly, they're just not themselves. They're confused, they're agitated, they're even seeing things that you know aren't there. It's gotta be one of the most frightening and unsettling things you can go through, right? Well, that scary situation? That's exactly what's happening in the case we're looking at today. We've got an 86-year-old man who's been brought into the emergency room. And get this, just a few months ago, he was living on his own, totally independent. Now, he's wandering around at night, he's agitated, and he's seeing people who aren't there. That sudden change, that's our first huge clue. And that brings us right to the heart of the mystery here. The big question the medical team has to answer is, what on earth is going on? Is this some kind of sudden, reversible problem? Or is it the progression of a long-term chronic one? And to figure that out, you absolutely have to know the difference between two things, delirium and dementia.
So in a situation just like this one, the number one suspect is always delirium. And here's why. It comes on fast. We're talking hours or days, not months or years. And a huge giveaway is that it fluctuates. It goes up and down. Our guy, for example, was drowsy all day, but then became super restless and confused at night, you see? This isn't some slow, steady decline. It's more like a chaotic storm kicking up inside the brain.
Okay, and this table really lays it all out side by side. Look at the onset. Delirium is acute. Bam, it's like a switch flips. Dementia, on the other hand, is that slow, gradual fade. But honestly, the most important line on this whole chart, it's that last one, reversibility. Because here's the thing, delirium is often reversible if you can just find the underlying cause. Dementia, sadly, usually isn't. And this right here, this is the crucial point, the one thing you really need to get. For an older person, the brain is often the canary in the coal mine for the rest of the body. Sudden confusion is a medical emergency. It's a blaring alarm bell telling you something else is wrong. Maybe an infection, a reaction to a new medication, something metabolic. It is never just old age.
But, figuring out the delirium piece of the puzzle, that's really just step one. To truly understand what's happening with our patient, we've got to zoom out. We have to look at the bigger picture. And this idea is absolutely fundamental to geriatric medicine.
And a massive part of that bigger picture is a concept called frailty. Okay, think of it like this. Your body has a physiological reserve, right? It's like a backup battery. When you're young and healthy, that battery is at 100%. But frailty means that battery is blinking red, it's almost empty. So a minor illness that a younger person wouldn't even think twice about, like a simple UTI, can suddenly become this huge event that triggers a total system breakdown. And this state of having almost no backup power, this weakness and slowness, it leads directly to a very dangerous consequence. It dramatically increases the risk for one of the most feared things in aging, falls. 1 in 3. Just let that sink in. 1 out of every 3 older adults living in their own homes will fall each and every year. It's like a silent epidemic, and it has just devastating consequences for a person's independence, their confidence, their entire health.
And what's so important to understand is that these falls, they are almost never just an accident. They're complex events that usually have a bunch of causes. I mean, just look at this list. A sudden drop in blood pressure when you stand up, sedative meds, poor vision, muscle weakness, even being on 5 or more different medications. A fall isn't just something that happens, it's a symptom, just like a fever is a symptom. So, we're dealing with delirium, frailty, and a high risk of falls. Where do we go from here? What's the path forward? Well, this is where the whole philosophy of palliative care becomes absolutely essential. It really focuses on 3 C's: care, comfort, and communication. Really, at its core, palliative care is all about reducing suffering and making quality of life as good as it can be right here, right now. So for our 86-year-old man, the main thing causing distress is agitation and confusion. For someone else, it might be trouble breathing. And so often, it's pain. The whole goal of palliative care is to relieve that suffering, whatever the underlying diagnosis might be.
And this is a brilliant example of the structured approach to managing pain. It's called the WHO analgesic ladder, and it's basically the global standard. It's simple. You start with the most basic, safest option. If that doesn't cut it, you move up to the next step. It's just logical, and it works. Now think about our patient. What if his delirium was actually caused by a painful, hidden infection? In that case, managing his pain properly wouldn't just make him more comfortable, it could actually be the key to clearing up his confusion. But here's the thing. You can have the best medications and treatments in the entire world, and it's still not enough. There's another pillar of great care that is just as important, and that's communication. How we talk with patients and their families, especially when the news is tough, that can be just as healing as any pill you can prescribe.
And this isn't something you just wing. There are actually frameworks for this, and the SPIKS protocol is a fantastic, compassionate roadmap. Let's think about our patient's family. First, S is for setting. You find a private, quiet place. P is perception. You ask them, what's your understanding of what's going on? I is for invitation. You ask permission. Would it be okay if I shared what we've found? K is knowledge. You give them the information in small, clear bits. And then E, this is huge, emotions. You pause and you acknowledge their feelings. Finally, S is for summary and strategy. It takes what can be a really dreaded conversation and turns it into a structured, humane process.
So look, if there is just one thing you take away from all of this, please let it be this. A sudden change in an older person's ability to function, I don't care if it's confusion, a fall, or just new weakness, that is a massive red flag. It's a sign of a serious underlying medical problem that has to be investigated and treated. And really, that brings us to the final thought here. All of these tools we've talked about, diagnosing delirium, understanding frailty, managing pain, communicating with real compassion, they're all pointing to one thing. They're all in service of one central goal: honoring the person and supporting their dignity, no matter what their age is or what illness they have. So the question this whole case leaves me with, and maybe you too, is how can we all get better at doing exactly that?